welcome the ETSU Department of Psychiatry's Grand Rounds. Before I introduce Dr. Komrad, he's going to be, after the lecture, he's going to be given a questions session for the next hour for anyone who wants to stay from the audience. Dr. Komrad is a psychiatrist on the clinical and teaching staff of Sheppard Pratt Hospital and the Johns Hopkins Hospital in Baltimore. He's also a clinical assistant professor of psychiatry at the University of Maryland and on the teaching faculty at Oceana University of Medicine in Samoa. He earned his undergraduate degree in molecular biophysics at Yale University, his MD at Duke Medical School, and trained in internal medicine and psychiatry at Johns Hopkins for his residency. He was an attending psychiatrist on the treatment-resistant psychotic disorders unit at Sheppard Pratt Hospital for 15 years, where he continues to train residents in psychotherapy and psychopharmacology. He also runs the Ethics Consultation Service and Hospital Ethics Committee for the Sheppard Pratt Health System throughout Maryland. Dr. Komrad has written multiple articles on ethics and lectured widely on this topic across the entirety of the country. And he's also got a book, You Need Help, a step-by-step guide to convince a loved one to get counseling, which was published in 2012. Dr. Komrad.
Can you all hear me? Am I coming across overhead? Excellent. Well, thank you very much for inviting me today. I've been on a journey around the country to discuss this particular topic, feeling a little bit like Paul Revere, trying to wake people up and alert them to something that's happening that I believe is coming here. And I want to share some of that with you today. But first, I have to give you my disclosure statement and to remind you that even though I'm an ethicist, we can all be friends. I guess I can say this is an ethical presentation because I have nothing to declare. So, as an ethicist, I'm interested in philosophy. Ethics is a branch of philosophy. And really, Camus was the first to say that in philosophy, there is but one truly serious philosophical problem, and that is suicide. And I really do believe that of all the things that I have been involved with as an ethicist, some of the dilemmas that come to me and to the committees that I'm on. I'm also on the committee for the Ethics Committee for the American Psychiatric Association. So we hear cases from all over the country. I think that what we're going to talk about today really has felt to me like the most serious matter that I have confronted in the 30 years of my career as a medical ethicist. Almost as if everything that I've been doing heretofore has prepared me for what I consider to be, for me, one of the defining, focusing issues of my career. And I want to transmit that to you. And as such, I do want to say that I have a point of view. And there's almost no way to avoid a point of view. And so I'm not here to necessarily present you an even-handed discussion. Perhaps many might agree that it's kind of like this election where it's very difficult to treat things even-handedly between the two candidates. They're so very different. And as Melville said, woe to him who seeks to please rather than to appall. And actually my agenda today is to appall you a little bit. And generally when I give this talk, it arouses a great deal of thoughts and feelings. And if those of you who can stay afterwards, I'll be glad to facilitate a discussion about some of the thoughts and feelings that come up in this. You know, before I do this, I do want to say that this morning, I spent a half an hour on the phone with a patient who was suicidal, reminding me that what we do as psychiatrists and as mental health professionals is that we have a certain posture toward suicide. And that posture is historical, that posture is ethical, that posture is very much the definition of who we are and what we do. We are the professionals who have charged ourselves and are charged by our society, both on an individual level and on a public health level, to push against suicide, to fight against suicide. But I'm now going to show you that that charge is beginning to change in some countries. And I very much fear, as do many other ethicists, that we will be confronting this on our own soil sooner rather than later. So this all started for me. I actually didn't realize what was going on until last summer, the summer 2015, when this came across my email, this article. Belgian doctors ruled that a 24-year-old depressed woman has a right to end her life. And I was shocked, I was amazed as I read this article to discover the goings-on, and I ended up poking around and finding other things, such as this Newsweek article about what's happening in Holland. Euthanasia spreads across Europe, or this Washington Post article I've since been collaborating with this guy Charles Lane at the Post, who wrote, if you were a psychiatrist and a chronically depressed patient told you he wanted to die, what would you do? In Belgium, you might prescribe this vulnerable, desperate person a fatal dose of sodium pentothal. The New Yorker magazine had this whole article back June of last year. The death treatment. When should people with a non-terminal illness be helped to die? As I continued to poke around further, I came across this documentary by The Economist last year. And I have cobbled together a 3-minute montage from this documentary to give us a start on our discussion, because this certainly was something that had a deep effect on me when I saw this.
I'm Emily. I'm 24 years old and I'm from Belgium. And this documentary is about my request for euthanasia because of mental suffering. And when you see this documentary, I won't be here anymore.
When it comes to doctor-assisted dying, Belgium has the most liberal laws in the world. This is Emily's story. From the outside, she's a physically healthy young woman with a loving family and friends. It appears Emily has everything to live for, but she finds her life unbearable. In 2013, there were more than 1,800 doctor-assisted deaths in Belgium. While 97% of cases involved people suffering terminal or chronic physical illness, 3% were people suffering psychiatric disorders, the most extreme and controversial form of assisted suicide. Belgium is one of only 2 countries that allow it. Strict criteria have to be met before doctor-assisted death is allowed. Emily's case has to go through dozens of medical professionals and ultimately be signed off by 3 doctors, one of whom is psychiatrist, Dr. Lieve Tienpont.
Ik weet niet of dat jij nu op dit moment zit je zelf met vragen die je wilt besproken zien.
Voor mezelf de laatste weken is de destructiviteit ook weer serieus toegenomen.
Emily started her application to end her life nearly 2 years ago.
Ik denk dat de meeste, of om niet te zeggen eigenlijk alle mensen met een euthanasievraag op basis van psychisch lijden, hebben een lang verhaal van psychisch lijden. Dus dat is helemaal verschillend van iemand die een acute depressie doet, bijvoorbeeld naar aanleiding van een rouw. Dat is juist de inschatting van de artsen en de 3 artsen die met de patiënt bezig zijn. Want binnen psychiatrie, de mogelijkheden zijn oneindig. Medicatie, combinatie van medicatie met ambulante residentiële therapieën kunnen we verder doen. Maar het moeten eerlijke kansen zijn waarvan we echt weten dat het perspectief kan bieden. En bij sommige mensen hebben we die niet, zoals we dat in sommige kankersituaties ook niet meer hebben. Is dat ook zo bij psychisch lijden? Soms hebben we niks meer te bieden.
I would strongly encourage you to go to YouTube and put it in 24 and Ready to Die and watch the entire 30-minute documentary. Spoiler alert, because I'm going to tell you how it ends. We follow her and she mugs for the camera, looking out over the rooftops of Brussels and saying goodbye to her friends, and all of her friends crying. We go all the way in to the bedroom where the doctors come in and set up the lethal injection, and at the last minute, she relents. Obviously, being in an economist-sponsored documentary to show to the world gave her sufficient meaning in her life that she decided that she wanted to continue to live. But I do want to encourage you to see that. So I felt that I missed the memo, and that it turns out this stuff had been going on for 15 years. And I began to feel like, look, that may be going on over there, but it's going to soon be coming here, and that we need to pay attention. I felt like the period before World War II, the isolationist period, where everybody wanted to say, well, the stuff that's going on in Europe, that's Europe's problem. That crazy stuff that's happening over there, we can stay out of it. And I really want to try to encourage everybody that I speak to that, no, we can't stay out of it, and I have gotten very much into it, and I'll explain to you how. All right, so let's get into a couple of pieces of terminology here to start this discussion. In Alice in Wonderland, the Red Queen says, a word means whatever I want it to mean, nothing more and nothing less. So the phraseology that is used in these discussions kind of depends on your point of view, right? It's a little bit like right to life versus choice. So we have physician-assisted suicide, or compassionate assistance to die, or physician-assisted dying, or voluntary euthanasia, or aid in dying, or death with dignity. Many of you may remember good old Dr. Kevorkian, who tried to coin a term for us, medicide. And if we didn't have enough terms, we now have the term dignicide, which is being promoted by this interesting and strange organization, the World Federation of Right to Die Societies. So people which keep trying to modify the language in order to create the connotations that they want. So it's very interesting to see these ideas. My gradkins came to visit. They talked mostly about world politics and kept asking me how I felt about the euthanasia. So it's interesting how words get moved around in the different contexts. So let's, for the purposes of our discussion, I want to outline sort of 3 levels of increasing moral complexity. And the first is assisted dying or passive euthanasia. Now that is a horse that has been out of the barn for at least 25 years. That's the so-called pulling the plug, letting nature take its course, helping to facilitate making patients comfortable palliative care. You withdraw life support, although I probably should change that. You don't withdraw all support, you withdraw life support. The second level is physician-assisted suicide, which is actually where we're at now in discussions in the United States, as I'll show you shortly, with 5 states. That's where a doctor provides the means to a patient to help the patient commit suicide, typically a prescription that the patient takes on his or her own in whatever fashion the patient seems to pursue it. But we provide the means. That's physician-assisted suicide. And then finally, active euthanasia. That's where the doctor, like with Emily, sits by the bedside and gives you a lethal injection. And yes, that is happening. In fact, that's the primary method of administering death in Holland and Belgium, as we will soon see. So we're going to focus just on the last 2 today, and we're going to focus it on a specific way. There are 4 distinctions in this discussion. One is the distinction between people who have terminal illnesses and non-terminal illnesses. And by the way, the definitions of all of these things are very squirrely and very inconsistent. What exactly is the definition of a terminal illness? How reliable are we in saying that something is a terminal illness? Generally, the working definition tends to be 6 months or less to live, but again, that's very difficult to predict, and it's not consistent. Sorry, pushed the wrong button there. The second phase of the discussion is the distinction between, which we've already touched on, doctor giving you the means versus the doctor administering the means. Another dichotomy of the discussion is whether you are being monitored by healthcare professionals in the act of this taking place to make sure that it's done properly, or if it's unmonitored, given the means, you can go off to the woods and do it by yourself. That's another dichotomy in the discussion. And then finally, and this, of course, this audience understands, I've made a very blurry line between these two, the psychiatric conditions versus medical conditions, schizophrenia and mood disorders as opposed to ALS. But as you know, that may be an artificial distinction, one in which, interestingly, we are trying to very much mitigate and see if we can include psychiatric disorders among medical disorders, but I will tell you that it may have unintended consequences of backfiring, because if we're going to allow this for other medical conditions, and we've been saying psychiatric conditions are indistinguishable from other medical conditions, then we will find ourselves in a very difficult situation in places where euthanasia and physician-assisted suicide are allowed. But for the rest of this time, I want to keep the focus on psychiatric patients who are not terminally ill. That's what we're here to discuss this particular morning. That's the slice of this physician-assisted suicide and euthanasia pie that I have personally taken ownership of, to be involved in and to teach about. All right, let's give a brief history, though, of this. The whole word euthanasia, which means good death, ironically was coined by Precipitous Comicus. I thought that was kind of interesting. Somebody whose name is associated with comedy actually was the first. And as a matter of fact, he used the term in a comedy. So I don't know what he was thinking, had in mind, but there is an interesting historical link there. Plato has said suicide is disgraceful except when one's mind is morally corrupted and one's character therefore cannot be salvaged. Now, I don't know how accurate that translation is. I didn't translate it myself, but it has something to do with there are problems in mental life that seem to give Plato some exception to the rule that suicide is not a good idea. But of course, there were moral issues here because the word disgraceful itself is a moral issue. However, moving into our particular domain, Hippocrates, as part of the Hippocratic Oath that many of you may have taken, says, "I will not give a fatal drug to anyone if I am asked, and neither will I counsel a man to do so." Well, that was actually a distinguishing feature of the Hippocratic cult, because in fact, at that time, giving euthanasia to people, especially soldiers on the battlefield and so forth, was actually an accepted practice in ancient Greece and similarly into Rome. And the Asclepians, of which Hippocrates was part, distinguished themselves by saying, well, we are this group, we're calling ourselves physicians, who don't do that. So the very birth of the medical profession is grounded and rooted in this specific ethos. Now I'm going to jump over the Middle Ages and the church and all of that and bring it a little bit more into modern times. The first encounter in psychiatry that we have with physician-assisted deaths is this guy, Walter Kempster, who revealed to the newspaper in Milwaukee the story about how he was passing by a burn victim in a fire, and third-degree burns, terrible situation. He reached into his bag and gave her a morphine overdose and killed her. And it turns out that the practice was fairly widespread in the 19th century here in America, but tolerated. And this sparked a number of discussions, and it was a famous story in the New York Tribune where it was talked about, should we make this a legal practice for physician? And the big editorial there said legalization might make an honorable profession the subject of constant fear and suspicion. What are the consequences of knowing that one option that your doctor has in the treatment plan to provide you when you go is death? That there's something very confusing about that. Well, we can't review the history without having a stop in Nazi Germany. And the intellectual underpinning of the entire Nazi euthanasia program was a psychiatrist, Alfred Hoch, who wrote this book in 1920, Allowing the Destruction of Life Unworthy of Life. And in fact, it was psychiatrist Alfred Hoch, who coined the term death with dignity. That was the very first time it ever appeared in any kind of a published form. This became the intellectual manifesto on which, and by the way, this is a quote from the book, not even the Hippocratic Oath is really binding anymore. Development over the centuries has been retarded partly because of the Christian way of thinking. The intellectual level of the mentally ill person is that of very low animal life. This is a psychiatrist writing. We doctors know that in the interest of the whole human organism, single, less valuable members have to be abandoned and pushed out. And this inspired Hitler to write, "It is right that the worthless lives of such creatures, the mentally ill, should be ended, and that this would result in certain savings in terms of the hospitals, doctors, and nursing staff, and hence the development of the so-called T4 program, the very beginning of the Holocaust, in which psychiatrists shepherded their patients to the gas chambers. The very first people to have been killed in the Holocaust before the gypsies, before the homosexuals, before the Jews, were the mentally ill. And this was the edifice on which it was built, and we absolutely need to include this chapter in our history. By the way, I've been unable to find anything in the archives, and if anybody has any information, I'm still in search of, whether at the time the American Psychiatric Association knew about what was going on, protested about what was going on, in any way reacted to it. And I can't even find anybody who's old enough to have been a psychiatrist back then to have a personal memory, let alone archives. All right, let's move into the modern era as symbolized by Dr. Kevorkian. Where are we now in the modern era? There are 5 states that, as of today, have legally physician-assisted suicide. Not euthanasia, the second level, providing the means. And in the United States, at this point, it is strictly for people who are terminally ill. Oregon was the first in 1997. At that time, a poll showed 56% of psychiatrists were in favor of it. In 2014, there were at least 105 deaths. Believe me, not every case is being properly recorded and documented. The vast majority, almost 90% of those, are unattended by the physician. The patients are getting their prescription and doing it themselves with their families alone, et cetera. You can see the other states that have since come online. Here are the states in which it's been so far explicitly defeated, most recently New Mexico. But that doesn't mean it's not going to come back. It was actually defeated in my state of Maryland, but I guarantee you it's going to be on the legislative agenda next year. I know all the people who are pushing it. But again, we're talking about the terminally ill. All right? Now, what about people who are not terminally ill? What about people who have just psychiatric disorders? Well, that's not legal. That doesn't mean that it's not being done. Lawrence Egbert, who was actually on the same faculty of Hopkins that I am, who passed away this summer in June. This is the board action against Dr. Egbert for 2 cases. He helped an 87-year-old woman with worsening depression who was not terminally ill, and a 76-year-old woman with just depression, helped them to commit suicide. He was the medical advisor of this so-called Final Exit Network. And they have this book, The Final Exit, The Practicalities of Self-Deliverance, and Assisted Suicide for Dying by this guy, Derek Humphrey. In the book it says, "Follow my instructions for a perfect death. No mess, no autopsy, no post-mortem." So this guy Egbert got nailed by the board, and in a number of other states helped psychiatric patients to suicide, and was actually preparing for hearings in those states, and then he died. He did not administer his own death. So it's happening here in the United States, but it's certainly happening illegally off-label. Now, Canada is way closer. In 2014, physician-assisted suicide, remember, giving the patient the means, was legalized in Quebec, but for only terminally ill. In February 2015, the famous Carter versus Canada case in the Canadian Supreme Court, and the Canadians said you cannot, the Supreme Court said you cannot limit this to only the terminally ill, that it has to be has to include the non-terminally. In fact, the case, Carter, in Carter versus Canada, was a case of ALS. So the Supreme Court said you must make this available, and you must make it available for the non-terminally ill, and it has to be available for situations of grievous and irremediable conditions. That was the language of the Supreme Court. By the way, irremediable can mean I can treat you, but you can say no. I can offer you ECT, and you can say no. And if you say no, and I think ECT is the only thing that's going to help you, then it is irremediable by definition. So it charged Parliament, Canadian Parliament, to come up with a law for this. So the Canadian Parliament met, and they tried, the committee that studied this recommended that it be available for the mentally ill, that it be available for proxy consent for competent children, that they make available euthanasia advance directives, so I can decide now that when I'm incompetent 20 years from now, I want you to give me euthanasia. That if you're a physician who refuses to do it, you are obligated by law, they wanted to say, to refer to a doctor who will do it. So you got to be a part of the machinery, even if you're not going to be the end person in that machine. You must make sure the patient gets moved along towards death at their request, at least as somebody who's willing to consider it if you're not. And if you're a publicly funded institution, incidentally, most hospitals in Canada, unlike the United States, are Catholic hospitals. If you receive public funds, if you refuse to provide this service at your hospital, that your federal funds can be taken away from you. That's what Parliament wanted. The Trudeau administration pushed back, and in just April of this year, they achieved a law that had available for the terminal and the non-terminally ill, but excluded the mentally ill. So Trudeau's mother has bipolar disorder, by the way. That may have been relevant. No advance directives and no children. So Canada is right there on the verge. So you think we're safe, but in June, the federal court in Canada heard a case of a woman with conversion disorder who wanted to have physician-assisted suicide, and they determined persons with a psychiatric illness are not explicitly or inferentially excluded if they fit the criteria laid down by the Supreme Court, the appeals judges said. So the court system is pushing back and saying, look, you may have passed a law that said you can exclude people with psychiatric disorders, but we're saying that doesn't have significant legal basis. So I will predict that within 1 to 2 years, psychiatric patients will be able to avail themselves of this technology in Canada. Let's talk about where it's been going on for over a decade, the Low Countries, Luxembourg, Netherlands, and Belgium. I'm just going to focus on the first two. All three of them in 2002 enacted a law, and with significant features. They decided that it was possible to have a doctor provide the means or administer the means, that they took away the distinction between terminal illness and non-terminal illness. They took away the distinction between physical and mental suffering. So suffering is suffering is suffering, and it doesn't matter if it's, you're in terrible rib pain from a metastasis, or if you're experiencing the mental suffering of a psychiatric disorder. They instituted these terms that we can debate and argue what terms they mean, especially in psychiatry, untreatable and insufferable, which almost in a way is practically definitional of psychiatric disorders. Psych patients are eligible as of 2002 in these countries, and doctors can either provide the means or give a lethal injection. First, let's look at some data now, and some specifics. Let's look at the Netherlands. Again, since 2002, the request has to be voluntary and well-considered, repeatedly asked. You have to meet the criteria of unbearable and irremediable without improvement. The patient has to be informed of the options, and just like in Canada, okay, untreatable means untreatable with treatments that the patient is willing to accept. Now look, we're psychiatrists here, and we understand the issue of compliance, the issue of resistance, the issue of psychotic denial, the whole paradigm of involuntary treatment, but patients refusing, that does count as as untreatable. Now, at least one outside physician, independent, must be consulted and concur. If this is a psych case, 3 are recommended, but not required. And one of those 3 should be a psychiatrist, but not required. Okay? Think about that. Psych patients. So you could bypass ever seeing more than one other doctor who doesn't even need to be a psychiatrist to get your euthanasia card in the Netherlands. And the physician may end patient's life with due care and medical attention. And again, you can give the patient a prescription or you can inject the patient. So in the Netherlands, from 2008 to 14, there have been over 26,000 people euthanized. It's been about a 300% increase since it's been first instituted in 2002. As of 2012, almost 3% of every single death in the Netherlands has been produced by a physician. 55% of physicians have been asked by at least once by their patients for this service. Here in the US, a similar survey, it's 20%, but it's not much of an option here, at least in those, except for those 5 states. 60% of the requests over that time have been granted. In the states where it's illegal here, only 5% of requests are granted. 1% of the completed euthanasias in the Netherlands were psychiatric-only cases. Somewhere between 200 and 300 different reports differ. And about 16% had problems with completion. It didn't work. Right? Think about, death penalty. Doesn't always work. So in the Netherlands, there are 2 paths. One path is through your personal physician. The other path is through one of the so-called end-of-life clinics. They are in buildings. Sometimes they're in trailers that travel around to the countryside. The end-of-life clinic, you can start there, or if your personal physician refuses to do it or is uncomfortable doing it, you can decamp to the end-of-life clinic. So this is one paper with 10,000 requests of all diagnoses for euthanasia, both terminal and non-terminal patients in the Netherlands. Of those 10,000, only 400 resulted in a request for a psychiatric consultation. 30% of those consultations granted the patient's request. 70% refused because either they felt there was really no psychiatric diagnosis, or it was not very well considered, or it was felt that transference and countertransference issues were way too caught up in the decision. We'll come back to that in a moment. So it's focusing specifically on psych patients. We're going to look at both paths. First, via your own doctor in the Netherlands. So in this very important paper that came out earlier this year, there were 66 psychiatric patients who died by injection or self-administration between 2011 and 14. 52% had the diagnosis of personality disorder. 56% refused one or more recommended treatments. And why did they refuse? They were skeptical that these treatment alternatives would be effective. 20% were never treated as inpatients, right? You want to think about what is a sign of a very significant treatment effort, an aggressive treatment, right? It would be inpatient treatment. 20% of the people who were killed has never once been an inpatient. 38%, I mean, think about other sort of things that we associate, for example, with treatment-resistant depression, ECT, MAO inhibitors. 38%, only 38% had ECT at one point, only 11% had ever been on an MAOI. 66% cited their major motivation for wanting this was because they felt lonely and socially isolated. 24% of the cases, the independent consultants disagreed, but there was one said yes, another if there was more than one consultant. Even though the consultants couldn't agree, in 24% the patients were euthanized anyway. And half of those cases, the particular reviewer, the particular consultant who objected was a psychiatrist. So they overrode the psychiatrist's objections. And yet, the review committee from the government that looked at this nevertheless concluded all these cases were found to be handled with due care. 73% of psychiatric patients who were killed in the Netherlands in those 3 years were killed by their own treating psychiatrist. Not by, I'll send you down the street. No, I'll kill you. 73% of the time. Now, what about the end-of-life clinics? So here's one paper, 645 requests. Now remember, a lot of the reason people go to these end-of-life clinics, these Lebenseinde-Kliniken, is because their primary treater is not willing to do it. 85% of patients were in that category. They granted 162 of those requests, 25%. I want you to keep that 25% in mind. We're going to come back to that. All right, of those 162 granted, 98 were killed by the clinic, 23 were killed by their own treating physician. Now, of those requests, 121 of them were psychiatric only, mental disorders. 45% of those were actually denied by their own treating physician or reviewers, and that's why they ended up at this clinic. Of those 121, 6 requests were granted. Half of those were executed, pun intended, by their own treating psychiatrist. That's about 5% of the patients. About 40% of patients, the primary diagnosis on the forms that were archived, that this data comes from, the primary diagnosis was tired of living. And of those people who fell into that category, I mean, you can see how this thing has gotten out of hand. 20 of those 40, 11 of those tired of living patients were granted. That's about 20%. Okay? So here are 2 publications, one from the Dutch Psychiatric Association, another from the Dutch Medical Association, guiding physicians about how to handle this in a country where death is an option for a treatment plan. So from the Dutch Psychiatric Association, I had it translated, and just some of the things, I'll share with you a few of the things in this pamphlet that you get if you're a Dutch psychiatrist. You're told that about 300 people annually emphatically, repeatedly ask their psychiatrist for help to suicide, and that ordinary suicides, wild-type suicides, are traumatizing for everyone and can be, go terribly wrong, and therefore the hope is that doing it this way will head people off. If they're going to kill themselves, let them kill themselves more painlessly, more dignified. So that's the sell here. In exceptional cases, then, a request for a suicide should be granted after careful assessment. And they spell out guidelines that spell out the definitions for things like what does hopeless and unbearable mean, and voluntary and well-considered, and no reasonable alternatives. So the Dutch Royal Medical Association also published their pamphlet. Now, in 2011, about 31% of people said that you shouldn't give it to psych patients. This is general physicians. But 2 years later, the Dutch Medical Association said, well, wait, we've gone over the edge here. And they published this pamphlet. Just because we can doesn't mean we should, because by then, 60% of physicians in Holland, after having a couple of years to see this thing spin, decided, no, doing it for psych patients is inconceivable. So in just 2 years, there was a significant change in the opinion of physicians. This guy, Theo Boer, who I've actually spoken with, prominent ethicist in Holland, was pushing for physician-assisted suicide back in 2002. So now in 2014, he had argued that it was a good euthanasia law would produce relatively no numbers of death, but based on how it played out, he said, now the very existence of euthanasia law turns assisted suicide from a last resort into a normal procedure. And now it's gone even a step further. Now there's agitation, including support from a parliamentarian, to make a non-prescription suicide pill available in pharmacies for people who don't meet the criteria, or that the system will not allow them to get their suicide requests fulfilled by the medical establishment, and they're going to be doing a pilot study for that. All right, let's move over to Belgium. So in Belgium, there's been a 27% increase in deaths of this fashion between 2012 and 2013. By 2013, 4.5% of Belgian deaths are through this means. Remember, it was a 2.8 for Holland, so they're way more active in Belgium. In those years, over 3,000 people euthanized. In Belgium, this is a service that you have in the hospital, including the psych hospital. You know, you go down the hall, and there's a surgical suite on the left and the ECT suite on the right. And beyond that is the euthanasia suite. 8.5% of all people who died in this way in Belgium, almost 10%, had non-terminal illnesses. 3% had psychiatric-only illnesses. So you saw this lady in the video, Lieve Thienpont. She is the leading proponent. She is, to Belgium, what Kevorkian was to us. I actually find them have some remarkable similarities in their visage. She wrote this book, Libera Me, on euthanasia and psychological suffering. As you might well imagine, just like in Oregon, the majority of cases are traceable to a handful of physicians. It's not terribly widespread, but she is the number one. So she published this paper in the British Medical Journal, looking at the first 100 psychiatric patients that she considered. She said they were all found competent, even though 14 of them were psychotic. So I don't understand that. That seems paradoxical that you could have psychosis and be competent to make this decision, and we can talk about that. 48 were accepted. That's 48% acceptance rate. Remember back in Belgium, Holland, I told you, remember 25% acceptance rate. So here in Belgium, almost 50% acceptance rate. 35 of those, 73%, went on to be euthanized, mostly in their home. And mostly in Belgium, it's injection. 7% in a clinical setting. So what are the diagnoses of these first 100 patients? Well, as you might well expect, major depression tops the list. But as you might also expect, personality disorder, comorbid or uniquely, is the second most common. But look at all of the others. I mean, somatoform disorders, dissociative disorders, complicated grief, ADHD, fibromyalgia. It's interesting on that list. What personality disorders? Well, I think this audience won't be surprised to find out what the majority personality disorder is. They cover the spectrum, but more than half, I'm sure you recognize and anticipated that. But, you know, here's one case just to show how far they go. This is a man who is fighting and was successfully granted the right to euthanasia because of struggling with sexual identity, specifically homosexuality. He just had dysphoric, ego-dystonic homosexuality and been struggling years and years and years with it, and he was granted euthanasia in Belgium. One Catholic nursing home is actually currently fighting a battle because they're being fined for refusing to allow, because this takes place on, they're refusing to allow a patient who got a euthanasian permission to leave and go and get her euthanasia. All right, so let's look a little bit at some of the ethical aspects here. A number of medical societies around the world have put this in their code. The AMA is categorically against it. The World Medical Association is categorically against all forms of physician-assisted suicide. But focusing on psychiatry, really the strongest statement in the world is by the Australia-New Zealand psychiatrist, saying that it just doesn't support it where a patient suffers from psychiatric illness alone. The Canadian Psychiatric Association is a little more wishy-washy. It talks about people are vulnerable, we should be careful, it should be studied, but are not explicitly against it. Similarly, the World Psychiatric Association, we should be particularly careful. Psychiatrists should be aware that it may be distorted by illness, so absolutely not categorically against it. But I will tell you that the Ethics Committee of the World Psychiatric Association has just come out with a very strong statement that is going to be voted on in their World Conference in Berlin in 2017. The APA we're going to get to before we finish. So here are the arguments. The arguments of the supporters are, first, the arguments are from parity, which is what we've been saying all along. Our patient shouldn't be distinguished from other patients. Mental suffering and physical suffering should not be distinguished as separate categories. And that psychiatric patients are at least potentially capable of the same degree of competence and capacity that we see in medical patients. And if we feel that medical patients, ALS people and MS people are capable of having sufficient capacity to make this decision, then at least potentially our psychiatric patients are. And that the usual standards of competence should apply. We'll get back to that in a second. And that ultimately there do exist some patients who, even though they have a psychiatric disorder and suicide is part of the phenomenology of their clinical presentation, that they are no less capable of rational suicide than other patients. So that's, and that they seek a parity between, that, and they say there shouldn't be any ethical distinction between passive euthanasia, pulling the plug, letting nature take its course, or giving a lethal injection. That it really is all the same. And if it's okay to pull the plug, it's okay to give a lethal injection, goes the argument. Clearly, autonomy, self-determination are the driving moral values here that underlie these arguments, and beneficence. Doing good for the patient, doing the right thing, and that ultimately we're trying to relieve patients of their suffering, and if that relief of suffering involves death as the really only form that we can provide that relief, then that is within the scope of the charge of beneficence as an ethical construct. And that if society says that a patient has a right to have this, that whenever there's a right, there's a duty. And if we give patients the right, that means that the physician has the duty to fulfill that right. And they argue from a public health point of view that having the option to do this may actually deter people from suicide. Knowing they can always do that, that's always available, will allow some people to live. Something which I'll show you in a moment doesn't stand up to epidemiological scrutiny. And that this is a more certain method, less messy method. So if people are going to do it anyway, we've already seen that. So always in medicine there is a dynamic balance between paternalism and autonomy. But there are some places like the Netherlands that long ago legalized marijuana, legalized prostitution, now is doing this with euthanasia, where you can drive the autonomy train, in my opinion, off the rails. Here's a Dutch ethicist arguing that in fact we should take it not just for competent psychiatric patients, but for non-competent psychiatric patients, making an ethics argument for euthanasia by proxy, that having a proxy consent. I see that you're suffering, I'm your guardian, I've considered everything, I've determined for you that the only way to relieve you from your suffering is to have your doctor injection. So that's where they're at in this argument overseas. Now, the arguments against, I think, are numerous, but I'm just going to cover a few important ones. One is the whole idea that, okay, I can know how treatable this is and what the prognosis is. Prognosis depends on diagnosis. And this audience, more than anybody, understands the squirrely reliability of diagnosis in psychiatry. So actually in all of medicines, but particularly in psychiatry, where we're a phenomenologically based diagnostic system, we don't have another domain of validation like an EKG or something like that to be the, or cardiac enzymes to validate our phenomenological construct. So, to say, look, I know what this patient has, and I know the treatments that are right for this, and I can tell you the prognosis, really depends on the diagnosis, and we don't have that. We also have a great deal of complex comorbidity. End-stage liver cancer is not necessarily commonly accompanied by a lot of other comorbid conditions. Ours are, including, not limited to, but very importantly, personality disorder, right? Even when we think we're in the right diagnostic channel, the prognosis of our illnesses are also very unpredictable. And there are so many treatment options, right? And, there's not just somatic treatments and psychotherapy treatments, but there's residential treatments. there's group treatments. And I mean, I don't have to list them to yourself. So actually, this is what the psychiatrist in the film was saying. You know, well, there's this, and there's this, and there's this, and there's this. We actually have many more treatments available for our conditions. So, you know, there's a real question. Is there actually any such thing as an untreatable psychiatric illness? And I think that's part of the discussion that we need to have. I want to maintain personally, there is no such thing as an untreatable psychiatric illness. And we can debate that if you want afterwards. I'll just put that out there. The whole issue of capacity, our whole capacity evaluation system, is really geared to lesser decisions. And with increasing need for more sophisticated capacity at these, you know, all the way from having a proxy decision maker to making decisions about research. And now we're in a domain that's never been explored before. The highest degree of capacity, which is the capacity to decide, I want to die, and I give you permission to kill me. So the whole world of capacity, this Louis Charlin said, the determination of decision-making capacity is a matter of considerable controversy among researchers and clinicians. It's doubtful that our current knowledge and practices governing the determination of decision-making capacities will be able to bear the weight of the new federal legislation in Canada. This guy's writing in Canada. Transference and countertransference. How easy is it to be infected by the hopelessness of your patients? Projective identification. We know about these things as psychiatrists, that patients can recruit us unconsciously into their hopelessness, into their helplessness, and that we can become colluders with that hopeless and helpless. So this particular study, looking at cases in Holland, showed the degree to which transference and countertransference were considered a volatile part of the situation by consultants. Societal considerations. John Mayer, editor of the Journal of Ethics and Mental Health, wrote this summer, should society's failure be a legitimate source of intolerable suffering? Are we pushing people towards wanting death and then perversely offering a legal path to that end? Shame on us if we are. Because think about this as providing a short circuit, a shortcut from pressures upon exhausted families, exhausted treatment teams, overspending insurance companies, overspending families with out-of-pocket costs and copays. You can imagine that if this and where this becomes a legalized option, that is a very tempting shortcut. The whole idea of advance directives, that if I write an advance directive now, will I really be feeling the same about it when I'm no longer competent? But it would certainly be convenient if my relatives knew that I didn't have to have the expensive treatment that occurs in the last year of life. What about implications for involuntary commitment? Somebody has their euthanasia card, hasn't used it, somehow or another ends up in your emergency room and is suicidal, right? So, but I've got my euthanasia card. Well, does that mean you don't hospitalize them? Does that mean you send them home? Does that mean, what if their family doesn't even know? What if it's confidential that they have their euthanasia card? Can you break your confidentiality to tell the family, I'm sending your suicidal relative home because he didn't tell you, but he's got a euthanasia card? This whole idea of lowering the threshold for suicide and the incredible mixed messages that gives. Here's a study in the Southern Medical Journal looking at what happened in Washington and Oregon after the institution of legalized physician-assisted suicide. What happened is that, in fact, it was predicted that natural suicide rates would go down. No, in fact, they took an uptick once you opened the door to legitimizing suicide as an option. So the data does not support that you discourage natural suicide by implementing assisted suicide. So in our efforts at public health, look at this. You know, you can go to the suicide prevention program or the assisted suicide. You know, let's not remember that as a profession, we're not just treating individual patients, but we're also advocating for mental health services. We're advocating for suicide prevention and suicide programs so that our public agenda would be very confusing. I'm both against and for euthanasia. I'm against it because it cuts life short, but I'm for it because it cuts medical bills short. So, if there's a right, society says you have a fundamental right, and this is what Kevorkian said, it's part of life, liberty, and the pursuit of happiness, and society legislates that. The question is, so that implies a duty. So whose duty is it? And I want to make a case of the fact that, is it the physician's duty? I do not think it is the physician's duty. And again, right now I'm focused on the slice of the pie that we agreed that we're going to talk about today. I think you can see my opinions about the larger matter, but right now I'm trying to focus on this. And in fact, you know, there have long been in societies professional executioners. This family, the Sanson family, was a family of royal executioners for France for generations. This guy was the official Virginia state executioner for the prison system for almost 20 years. So there's something critically important about keeping the roles of bringer of comfort and bringer of death separate, even if they're arguably on the same conceptual continuum. So I maintain that even though I hope society doesn't allow our patients to have access to, you know, facilitated suicide or specific death, that if our society wants them to have it, my role as an ethicist, as a member of the APA Ethics Committee, is to talk about what psychiatrists can and can't do, what physicians can or can't do. I would like to see, if society insists on this, let them stand up an alternate profession to perform it, not physicians. Because this inverts the fundamental ethos of who we are and what we do. Scott Kim, who collected a lot of this data that I've showed you from Belgium, says a core clinical imperative in psychiatric treatment, compassionately and skillfully helping patients, even through periods of sustained suffering, during which patients often lose the will to live. We have suicide prevention as a very core, fundamental, definitional ethos of what it is that we do. That our intention and our skill set, maybe even uniquely skill set in the mental health professions, is to ameliorate suffering, but also provide coping mechanisms in the face of discouragement and demoralization, to help people understand the context of their suffering, to find a variety of ways to have alternative paths to a better future rather than death. That's what we do. We are pathfinders. We help people find paths to a better future. We help mobilize their support system. And we even, if we can't completely ameliorate suffering, we not only help people cope with the suffering that they have, but we actually maybe can even help them find meaning in suffering. That's something that we have some skill set in. That is what we do. And to invert that ethos is to fundamentally change what it means to be a psychiatrist. And I would like to argue that that is a change that we should not tolerate. That is a change that society needs us to be what we are and who we are. So, to the APA finally. The APA does have ethical prescriptions. There's certain things you just can't do as a psychiatrist. You can't have sex with a patient or a former patient at any time for the rest of their lives, by the way. The American Psychiatric Association is the most strict of any professional body on that one. We cannot participate in torture. I mean, this is written into our ethics codes. The principles of AMA Principles of Medical Ethics with special annotations for psychiatry. That's our code. We cannot administer lethal injections to prisoners. That's in the code. So what we need is to include this issue in the code. So I'm a member of the Assembly of the American Psychiatric Association. I and a colleague, a forensic psychiatrist in Maryland, Ann Hansen, and I initiated an action paper, which is like a bill, that we took to the Assembly, and if the bill passes, it goes to the Board of Trustees, who's supposed to sign off on it, and then becomes official policy. Took it to the Assembly in May, and the Assembly unanimously voted for this resolution. Be it resolved that the Board of Trustees of the APA adopt the following position statement. The APA holds that a psychiatrist should not deliberately prescribe or administer any intervention to a non-terminally ill person for the purpose of causing death. So, if the board does what it's supposed to do in October when it meets, the APA will be the largest, most important, most influential and authoritative body of mental health professionals in the world that has not mealy-mouthed and wishy-washy like the Canadian Association or the World Psychiatric Association heretofore, to come out and definitively say you shouldn't kill your patients. It's not okay. It's not ethical. You shouldn't have sex with your patients, and you shouldn't help your patients to suicide. You shouldn't aid it and abet it and facilitate it and administer it. That's not what we do. So I'd like to think, and I can't tell you that it's official APA policy until the board votes on it, but if it does, I will certainly feel satisfied that my particular role in that quest has been fulfilled, because I think that will be an important statement. Many people in the Netherlands, Holland, Canada are members of the APA, and I've coordinated with the WPA, with Paul Applebaum, who's the chair of the ethics committee there. And by the way, our ethics committee, the APA ethics committee, also unanimously endorsed this statement as well. And the World Psychiatric Association Ethics Committee now has a similar statement, and as I said, that's going to be voted on in October 2017. So, here I am, Paul Revere. I'm saying the redcoats are coming. What's happening across the pond is coming here. And the thing is, it's going to come here on the coattails of the sacred tropes that we already have. Parity, anti-stigma, Americans with Disability Acts, the way in which we have been working, and all of these things are good, right? But everything has another side to it, a flip side. So under those sacred tropes will come the request, because there's no country on earth yet who has instituted physician-assisted suicide for the terminally ill, where it didn't gradually morph into the non-terminally ill, and then once that door is open and the psychiatric patients get in line, the non-terminally ill people who think a lot about wanting to die, where they don't get in line. So the fact that we already have 5 states and more will be coming online, having this for the terminally ill, these particular tropes, these Trojan horses, will contain the challenges, the ethical challenges of our future. That's why I call this an approaching tsunami ethically. So to close, my mentor, Paul McHugh, the former chairman at Johns Hopkins, wrote very eloquently about this topic back in the Kevorkian days. Patients are seduced by isolating them, sustaining their despair, revoking alternatives, stressing examples of others choosing to die, and sweetening the deadly poison by speaking of death with dignity. If even psychiatrists succumb to this complicity with death, what can be expected of the lay public? So, to close, the words of Winston Churchill: never give up, never give up, never, never, never. Thanks for your attention. So if you can stay, let's start questions and discussion. Yeah.
You talked about the non-terminally ill. So the way that's worded, I mean, you've defined what terminally ill, and we're talking about in the medical scenario, is what you've defined the 6 months. So when the APA is saying that, are they talking about it from the standpoint then of the medically? Because you've talked about psychiatry as your belief that there is nothing that's terminal, so to speak, within the psychiatric realm.
Right, so this was extensively discussed, and we decided that no, we should not limit this statement to the psychiatrically ill. That the so-called medically ill, I mean, look, there are many people who say, and I agree with this, Paul McHugh is a big champion of this idea, by definition, anybody who is suicidal has a psychiatric disorder. That's our wheelhouse, right? And so, I mean, frankly, my feeling is, even if you're going to have a law that says terminally ill people can do this, I actually think that the law should include the requirement that before a patient is killed, that a psychiatrist gets a crack at them. And the crack of them not being just decide if they're competent, which is the way laws are written now. And by the way, the individual physician doesn't even have to consult a psychiatrist. You know, like everybody has great skill and capacity evaluations. But I think that we should give a crack at it. Let us, mandate 10 sessions with the psychiatrist to see if we can turn it around. But if you're not terminal, especially more so, because we really feel that we can take ownership as psychiatrists. If we're not going to be able to take them of the terminally ill, and in many ways that horse is out of the barn. And by the way, there are a lot of psychiatrists in the APA who actually support physician-assisted suicide for the terminally ill.
That's
But
what I was
right,
clarifying.
but there are almost no psychiatrists in the APA that support it for the non-terminally ill,
Okay.
and definitely no psychiatrists who support it for psychiatric patients. I have to tell you, when the assembly of the APA votes, it's almost never unanimous. It's always contentious. This is one of the first time in years that the vote has been unanimous, which was in itself very telling.
The second question would be, and I don't know that there's certainly any solution, is you talked about how many possibilities there are for treatment, such that, we could look at endless possibilities. The bottom line comes, of course, on the cost. You may know what would be, give a patient a purpose in life
Yes.
for living. Their ability to have the cost, the family's cost, transportation, whatever, often limits. What are, I know there's a societal issues to deal with. Just wanted to kind of raise
Yes.
that.
Oh, it is very societal issues to deal with. Look, I can really turn you around like I've turned around a lot of patients by sending you to Cooper Reese, just up the road, by the way, in Asheville. A wonderful, state-of-the-art residential rehabilitation program where I've sent a number of patients to completely turn your life around. So, you don't have the $18,000 a month for the first 2 months? Your insurance company won't cover it? I'm sorry. Well, I guess all we have left is euthanasia for you. I mean, look, these are, and as one of the commentators said, you're going to say, look, we as a society will decide we're only going to give you so much, and because we as a society decided we're only going to give you so much, that means that we're also going to give you another option. And the other option is you can kill yourself. And we're going to give your doctors not just the permission to do that, but tell them it's their duty to do that. That this will now be their new role, so that we as a society say, no, you can't have access to those resources, but your doctor now has the right and the duty to help you kill yourself as your alternative. So I'm trying to protect, right now, I mean, I don't speak to legislators. My cohort in this, Ann Hansen, speaks to legislators. I speak to doctors and professional societies and, public policy people who want to drag doctors and psychiatrists, especially in this sense, kicking and screaming into doing this. And I'm saying we have ethics. We have an ethical construct. We have ethical limits and boundaries. There are things that we don't do. If you tell me, doctor, your patient would really, really benefit from having a sexual experience with you, it doesn't matter. I'm not going to do it. Yes, sir.
One of the things, the comments you just made struck me about two things about the overall social contract. When psychiatry first got started, for instance, social work was not around, and it became very evident that we needed to have a bridge into the community to actually see what was happening as opposed to just presuming we knew. And this social contract is very critical. I've worked for some time with lots of police officers.
Yeah.
And police officers will step into suicide situations with the intent to prevent the suicide, but throughout the time that they're doing that, they're very well aware that the suicidal individual may very well want to go off the building with them in arms, or the suicidal individual may very well draw a gun or something that looks like a gun to have a suicide by cop. And this has been a real rip in the social fabric for police officers.
Yes.
Another aspect of it is kind of the sociology of the economics. Of all the slides you produced, probably the most perverse was Hitler's comment about certain savings. And, it really strikes me that as we've gotten into managed care and as we've moved almost thoroughly out of the realm of paternalism for physicians, we have gotten into this place where Can you afford it or not? And now this becomes about life itself. And that is not what physicians have dialed into in the social contract.
That's right. I think this idea of the social contract is really interesting. And it's when I'm writing a book on this with a co-author who's a philosophy professor at Hopkins. And we talk a lot about the social contract. So society licenses us, right? And gives us privileges. And they give us prescription privileges and so forth. So the question is, what can society expect in return for the gifting of privileges in this contract that they make with us? How far can they push us to demand from us to do its will? And are there limitations on that? Or, you know, if I give you your license, if I say jump, you have to say how high. So, and I maintain that what it means to be a profession, and as a matter of fact, the venerable figure known to this audience, because he was my mentor at Duke, and he used to be here, Alan Dyer, wrote, some of you may remember, wrote a book on, you know, what it means to be profession and professionals. To be a profession is to profess. To profess what? To profess a certain set of values. Remember Hippocrates and the Asclepians saying, okay, this is what we do. This is what we don't do, right? And you're going to take this oath, and you're going to profess this oath, and this is what you're going to do. So I think it's very important, and this is where, that's why, can't you see why now, as an ethicist, I feel like, you know, wow, this is what I've been preparing for, you know, my whole career, ethics. Now, this takes ethics to a whole new level. Ethics is a way to maintain, prevent, protect, define who we are and what we do. And to be able to say, in the face of the pressures of the social contract, we have limits. We have limits. You can't, just because you give us privileges, you can't demand that of us. And frankly, then, you know, we may have to engage in civil disobedience. I mean, the fascinating thing was the Canadian Parliament that wanted to say, well, if you as a hospital or if you as an individual physician engage in some civil disobedience, there are going to be consequences for that. So it's shaping up, you know, a potential epic battle that's going on. Now, I'm trying to sort of sort things out, what's going on over there, and there's some people who are objecting to this. And there's some people who resigned from the Dutch Psychiatric Association when they put out that pamphlet, which said, okay, this is a law, and let us help you do this, and let us help you kill your patients in the proper way to follow the proper laws. And there are some people actually that resigned from that association. But you can see how ultimately these things may turn us against one another, right? I mean, it's bad enough we're fighting one another about recovered memories, you know, and trauma. This is going to be on a whole different level. That's why I think we need to be acting as a profession about this, as a professional body, which is what we do, you know, that's one of the purposes of the APA. Also, I feel like for those of you who think that the APA is some, you know, remnant or some sort of sideshow that isn't very important to belong to, I hope I've convinced you that organized medicine is actually the empowered and potentially effective, only effective way to go about this. That you individually standing there and saying, no, no, I won't do it, is not sufficient. That we need to be together on this.
Yeah, and that just leads me to a point that I'd like to raise, which is that this discussion is all about a doctor and a patient, as opposed to a doctor and a patient in a community. And the value and the importance of bringing in the community and the meaning of death for the social fabric, because we know that suicide has enormous ripple effects into families and creates its own sorts of problems. It's very interesting. I'm interested in the whole process of dying, perhaps because of my age, and but I've been reading a fellow named Stephen Jenkinson, who you may be familiar with. He actually, you know, wrote a book called Die Wise. He's very supportive of the kind of position because he believes that death is a community event. It's not an individual event.
Yes.
And I think that's part of the conversation that really needs to be brought into what is the social impact of this, as well as the individual's rights and, you know, and the doctor's duty.
Well, I wonder whether, as you've been thinking about this and reading about this, do you, in your own mind, parse the terminally ill from the non-terminally ill? or do you in your own mind parse our patients who are in our wheelhouse, who are, so many of them wanting suicide and who by very virtue of their illnesses are unable to tolerate it, so forth. Do you see them as exceptions to death-wise kind of arguments, or do you feel that, no, this encompasses our folks too?
I think I don't think we're ready for the whole assisted suicide question.
In general.
Period.
Yeah.
I don't think we're technically quite capable of doing it, but I don't think we really quite understand what we're doing.
Yeah.
At the very broadest level. In my world, which is your world, psychotherapy and working with psychological patients, I take a position very similar to yours in that particular world, because I worked with primarily ambulatory schizophrenic and very severe personality disorder clients for many, many years. Many of them were living on the edge of death for years at a time.
Sounds like my practice.
Only to emerge in ways that are really remarkable. And I don't think that anybody that I've ever seen, no matter how desperate, I've ever held that feeling that, this person will just kill himself.
Yeah. I mean, I think one of the strongest arguments is that almost every clinician you meet, seasoned senior clinician, will say, I've never seen a case in my entire career that I considered hopeless and untreatable. Because almost by definition, we're the holders of hope. We're the stewards of hope. We hold hope for a patient when a patient can no longer hold it for him or herself. But there is a danger in this parsing. I went to my mentor, Paul McHugh, and said, will you join, I've turned from a scholar into an activist. And I went to him and I said, can you join me in this? He says, not if you're going to focus on psych patients. Former chairman of Psychiatry of Hopkins. I said, well, why not? He said, because if you're focusing primarily on psych patients or the non-terminally ill or any piece, you are implying ipso facto that the other piece is okay. That if you say it's not okay for the non-terminally ill for psych patients, that you're implying that, well, we don't need to have the discussion because it's already okay enough that we can pretend that that's not there for a minute. And he's against, the whole thing, like the AMA is, and thinks that, when doctors start killing patients, the end is near for society. So, he warned me. But the fact of the matter is that, as you see, in 5 states, the terminally ill is out of the barn, and it is a metastasizing meme that is going to be spreading to other states. Just like, medical marijuana and, all the other memes. Yes, ma'am.
I just had a comment about what the risk is with the end-of-life pill of using it for murders.
Say again?
For using it for murders, for a person to acquire an end-of-life pill, what's the risk?
Oh, right, right.
Of using it.
For misusing it.
Yes.
Right.
For other
For
people.
misusing it. Right. We're so concerned now about the epidemic of opioid abuse, right? And it turns out that the vast source of abused opiates are not opiates that were prescribed to the abuser, but are found on the shelves of people who got it for a legitimate prescription who may not even be using it anymore, right? So imagine in Oregon, right, you got your suicide pill, right, and there's no law that says you have to keep it under lock and key like a gun, right? So right now, if your kid kills themselves with your gun because you didn't keep it under lock and key, there are no legal consequences to you. I mean, it's a horrible thing. You may psychologically suffer, but there are no legal consequences. Similarly, if your kid takes your suicide pill, there are no consequences to that. Yeah. Oh, you do? Okay. Does anybody else want to say anything? We're down to the last few.